Broadcast is now starting. All attendees are in listen-only mode.
Good morning, afternoon, evening to all participants to our webinar, which takes place. It's about integrating gender into health system strengthening in conflict and crisis-affected settings, and with a focus on how to do this, what's in our toolkit. We get back to this shortly, also with a short introduction, but first we would like to show you some rules of the game for this webinar.
Thank you, Egbert. Thank you for joining today's webinar. And to keep the technical process simple, we will not be using the webcams for this session. I would like to ask you to keep your microphones muted while listening to avoid the presenter background noise during this session. And please submit your questions and comments through the question box, which is at the bottom of the GoToWebinar control panel. And we will collect all your questions and panelists will try to answer your questions. In case you did not get an answer on your question during the live session, then panelists will get back to you later through the email. And now you're seeing my email address on the screen. So in case you have technical problems, please write to me. And I would like to ask you to complete the post-webinar survey, which will pop up on the screen shortly after the webinar is concluded. And your feedback will really help us to improve the webinar quality. Thank you, and over to you, Egbert.
Thanks, Nanuka. Can we see the next slide? So my name is Egbert Sondorp, and I will be chairing this session of today. And I think probably none of the audience has to be convinced that gender needs to be taken into account in health system strengthening in any case, but in particular also not in the case of conflict and crisis affected areas. But I think the question is how do we do that? I think that's what people feel much more uncertain often. So what we would like to do today is to see how we could focus on gender and how this is unfolding in different settings. And we will start with a few case studies to see how that actually can be done. But the main aim of today will be to show you a range of tools that researchers, policymakers, practitioners could use and adapt to stimulate the progress towards gender equity. And after that presentation, we'd like to hear back from you. What are the kind of challenges you are facing and what suggestions do you have on the tools being presented? You could do that immediately, but there will be ample opportunity to do this later on as well. And then finally, how can our global community of health systems researchers help in constructing the kind of evidence base that would guide good decision makers and facilitate best practice? The next slide, please. So what we aim to do, I will give a very brief introduction about a thematic working group on health systems in fragile and conflict-affected state that is hosting this webinar. Then we had hoped to give you a few country case studies, one from Sierra Leone, which will take place by Hajawuri. And then we had a small video because both of them, I think they are in the air. So they had recorded a video on northern Uganda, Sarasali, and Cambodia, Sri Tukvong. Unfortunately, that would compromise the quality of our viewing, so we cannot show it during this session, but I think it will be made available afterwards as well, so you can have a look on your own. And then the main thrust of our today's session will be this integrating gender in conflict and crisis-affected states, what's in our toolkit presentations by Val Percival and Amber Warnott. And then we will continue with hearing from you and having some questions and answers. The next slide, please. So briefly about the thematic working group on health systems in fragile and conflict-affected states, which I'm representing as well as part of the steering committee. And this thematic working group is a subgroup of Health System Global. I'm pretty sure that quite a few of you may be a member or maybe also a member of the thematic working group, but if not, Health Systems Global is a community, a society of health systems researchers organizing every 2 years a major symposium on health systems research. And beyond that, they are organized in a range of thematic working group, of which the health systems in fragile and conflict affected states is one. I think I'm pretty sure I can announce pretty proudly that we are the largest thematic working group I heard yesterday. And we are now a community of 800 researchers, policymakers, funders, and implementers. So if you're not a member yet, the next slide shows how you could potentially sign up. What we want to do as a thematic working group, we want to build this dynamic health policy and systems research community on our topic. We want to advance the field of health and planning and systems research in fragile states, and we want to engage with and support relevant communities. And I think, well, this webinar clearly fits those objectives, and we want to reach out to all of you to discuss this very important element of how to improve our focus on gender during the reconstruction of health services, health systems in post-conflict or during conflict phases. Could I see the next slide? So this is part of the website of Health Systems Global, which is also easy to find. And you could then go to the thematic working group by either on the top level, you can see thematic working group, and then it's the working group on fragile conflict affected states, easy to find, or you can go directly through this bit.ly/TWG-FCAS site, and then you can find how to sign up for it and become member of our community. Next slide. Yes, we are about to launch and ask Haja to address us with her case study on Sierra Leone. But before that, we would like to post a poll. We have a question for you, and we would ask you to answer the question, which you will see on your screen. So if it's okay, you now see this question: do you explicitly think about gender when making decisions about healthcare programming or healthcare interventions? And you can answer from the politically incorrect first one, no, I never do, or choose any of the following three answers. And here you can see the results of this poll, and you see that the great majority is at least thinking about this topic most of the time. Probably not too surprising with the audience, of course, this webinar attracts. It's not totally unbiased in this sense, but I do think that quite a few people quarter about think only some of the time, and it might have to do indeed with the way that you may think about it, but then how to do this. So now we'd like to move on. So could we go back to the slide of Haja? Thank you. And then give the floor to Haja Wuri and talk us through her case study on the post-crisis and health in Sierra Leone. Haja.
Okay, thank you, Egbert. Good day, everyone. I'm Haja. I work for the College of Medicine and Allied Health Sciences in Sierra Leone. I am a health systems researcher, and I work on a number of projects including the Rebuild project, which is about generating evidence to inform policy making in post-conflict countries. So I'm going to be talking about post-crisis and health in Sierra Leone through a gender lens. But before I do that, I just want to bring to your attention the Building Back Better webpage. So this is a website which condenses findings from research carried out by the Stockholm International Peace Research Institute Working Group on Gender and the Rebuild Research Consortium. And on that page, analysis includes literature review on health systems reform in post-conflict and developing countries. It also presents an examination of international priorities in gender equality, and also 4 country case studies of countries emerging from conflict. So, so you can see on your screen there screenshots from the webpage, which gives you the case studies from these 4 countries that I mentioned. Next slide, please. Thank you. So in the context of, just to give you a brief context of Sierra Leone, so as you may or may not know, it's a post-conflict country, and the conflicts disrupted the health sector, and then it was then hit by an Ebola outbreak, which brought about further disruptions to the health sector. And what this slide is trying to show is gender dynamics at different levels, specifically between the human resource for health pillar of the health system. So if you look at the bottom of the pyramid, where it says community level, what we have are community health workers, and they help bridge the gap between the community and the health system. And a new community health worker policy was rolled out quite recently. And the policy clearly stated that it would like more women to be recruited as community health workers. So it was somewhat sensitive to gender and societal norms, because they're well aware that in the context of Sierra Leone, at that community level, sometimes if a male CHW was to approach a pregnant woman to take them to the health or talk about reproductive health, it's not usually accepted. So the policy set out to address that gender and societal norms. But what actually happens in practice is that we have more men CHWs for a number of different reasons, ranging from the nature of the job. They have to walk very long distances in some cases. Some areas are only accessible by motorbikes. And if you take into account the caregiving roles that women play in society, some of them do not come forward. They don't put themselves forward to serve as CHW. And also you have some women who will not put themselves forward because their husbands may not be happy with them working as CHWs because they think that it will increase the chance of them being promiscuous. And then there are also some, with the new policy, there's more financial incentives attached to CHWs, and societal norms will dictate that men should have more earning power than women. So for a combination of all those different reasons, what we found in practice is that we have more men being CHWs as opposed to women. And then if you look at the middle of the pyramid where it has health workforce, what we have in Sierra Leone is that majority of the lower to mid cadre of health workers are female. So the maternal and child health aides, the state enrolled community health nurses, and nurses in general. But then if you look at the health workforce as a whole, it's largely demotivated for a number of different factors, ranging from access to training opportunities to lack of enablers. And one of another very key demotivating factor, which specifically affects women, is the posting policies, where health workers are posted to places away from their home, so they have to be separated from their families. And then at the top of the pyramid, where we have senior management level, what we found out in Sierra Leone is that senior management levels are predominantly male, and the gender disparities in training opportunities, as I said before, access to training is a motivating factor. But what we found is that this gender disparities makes men have more of an advantage. So if it's training opportunity that involves traveling outside of the region, more men are being put forward, and if it's national or regional, more women are being put forward for that one. And I think that also has something to do with the caregiving roles that women play in society as well. Next slide, please. So now I want to talk about the gender implications of the investment in the Free Healthcare Initiative. So this was something that was implemented in response to high levels of maternal mortality rate in post-conflict Sierra Leone. And it basically takes away the financial barrier for pregnant women, lactating mothers, and children under 5 to access the health service. So on the whole, it was a good initiative. But what that meant, because there's no financial barrier anymore, it meant increased traffic of service users at the health facility. And that translated into increased workload and responsibilities for the lower cadres of health workers, who, as I mentioned before, are predominantly female. And we have this urban-rural divide, where in general, rural health workers, the demotivation is across the board, but the rural posted health workers at a disadvantage, so to speak. So they're demotivated already, and then if you add in the factor of them having been separated from their families, it puts them at more of a disadvantage. And then we have gender shift deployment, where women are less likely to be able to take their families if they're posted away from home. It is expected for, if a man is posted away from home, the wife would follow, but if a woman is posted away from home, the husband and the children will most likely not follow. So it's that separation from their families, and that can bring about emotional strain. We also capture things like women in these postings away from their family, they're having to deal with issues of security and living in an environment that they're not accustomed to. Next slide, please. And then finally, during the Ebola outbreak, we found out that gender and societal norms shaped vulnerability. I'm trying to present from the health sector perspective and also from a community perspective. From the health sector perspective, the lower cadres of health workers, who are predominantly female, were the first point of call for service users. So that puts women at risk. And then if you look at it from a community point of view, in addition to women being, women are also at risk due to their caregiving roles in society. But then the men were also at risk because we had a group of informal healthcare workers who served during the Ebola outbreak within the burial teams. And these were mostly, I think all of them were men. So in that regard, men were also at risk while being involved in burial rites. Next slide, please. So that brings me to the end of my presentation on Sierra Leone, but I just want to draw your attention to a number of key references that you could explore to learn more about what I've just talked about. Thank you for listening, and I'll hand you over to Egbert.
I'm so sorry, I was muted, so you did not hear anything what I said. What I said that we will now move on to our next topic and discussing the toolkit. But please already start thinking about how you could ask some questions or have comments. You can start posting them already. We'll discuss them after the next talk. Including, of course, responding to Haja's talk, which she has just completed. So I'm giving the floor to Val and Amber, and they will take us through the toolkit, but they first will provide you some feedback on the survey which was posted and which quite a few of you have been responding to. So over to Amber and Val.
Hi everyone, thank you very much, Egbert. So just a quick go of the survey summary. The total number of respondents was 34. The background of respondents, most people were researchers, over 50%. Then came in second was other, and then practitioners, and then donors and policymakers were even. In terms of understanding the term gender, the average was 83, but the range was 32 to 100, which is quite wide. And then thinking about gender when making decisions in healthcare, the average was 77. The range was a little bit smaller, 50 to 100. Participants who received gender training, the average was 51, but the range was only the full gamut. It was 0 all the way to 100. Excuse me. The number of tools people have used, there was a number identified, but some of the key ones were the Moser framework, the Harvard gender analysis, and then intersectional analysis. There were also a range of experiences in conflict-affected areas. Some of these included working with transgender people, gender-based violence, and displaced persons. And then interest in the webinar included everything from working with gender nonconforming individuals, info on gender analysis and healthcare, and then even just basic gender concepts. And next slide, please. And this was, I thought that it would be important to see the full range of what people have been exposed to. So have you ever used any gender analysis tools that also examine any of the options below? So gender with women and girls was a really popular one, which we would have expected. But then there was some interesting ones where no one has been exposed to gender and colonialism, gender and resistance, gender and disability was quite low, as was gender and the class divide, etc. Next slide, please. And here we just took a couple of the interesting things that came up for experiences and concerns on working on gender and health in fragile and conflict-affected settings. So there's people working with transgender women in very conservative religious environments. It's been noted that hospital directors tend to be men and show very little consideration for the well-being of women. There's been exposures, risks, and protections differ markedly for women versus men, with sexual harassment risk dimension being overlooked often. It's essential, while insisting on creating opportunities for women and girls to attain equality in the marketplace, to also ensure that they are well trained to compete on an equal basis. It was also mentioned that people are looking to understand basic gender concepts. How do we do gender-based analysis and gender-based budgeting? And finally, looking for an understanding on how to do an intersectional analysis. And I'm going to pass this over to Val now. Next slide.
Oh, there, I'm not muted anymore. Sorry about that. Thank you very much. I'm so pleased to join you all today to discuss this topic and to follow on from Haja and Amber's excellent presentation. So we're going to delve right now into kind of what our toolkit is. Next slide, please. So we have been undertaking research as kind of a rebuild NIPSIA, Stockholm International Peace Research Institute Consortium, for several years now. And this research is available on our website, which Haja mentioned earlier. And our research looked at how health systems integrated gender in their interventions in fragile and conflict-affected settings. And one of the things that we found, our key finding, was that health systems research was gender blind, that health practitioners and policymakers tend to see gender as primarily an issue for women and girls, and they tend to focus on sexual and reproductive health needs. not enough attention is being paid to the health of men and boys or transgender individuals. And health policymakers and practitioners see health services as gender neutral. They see the provision of health services as a technical service. If you provide, if you ensure that your health system is adequately resourced and you're undertaking evidence-based interventions, that health service will be gender equitable. But what we found, as Haja showed really nicely in her analysis, was that health interventions are not gender neutral, that health interventions reflect the society in which they take place, and that gender inequities that are present in the broader system impact on health services. But when we've presented this research, people agree with us, health policymakers, practitioners, and other researchers. But the key question that we get asked is, what do we do about it as policymakers or as practitioners? What tools exist for us to be able to integrate gender into health policy and planning, into health service delivery? And so we decided that we would explore this question in an effort to be part of the solution. And this is one of the first steps in our effort to share the work that we've done on tools. Next slide, please. And I hope that this continues to be a conversation. But I just wanted to begin with some basic definitions. To undertake gender analysis, you need to know some key terms. So gender, as I'm sure you're all aware, is socially constructed roles, behaviors, activities, and attributes that society considers appropriate for men, women, and other genders. Gender norms are practices, the expectations and expected behavior that society believes is appropriate for men, women, boys, and girls. Gender equality versus equity, these terms can be used, are often used interchangeably, but they're quite distinct. Equality means obviously that individuals possess the same rights and receive the same benefits. But equity understands that different individuals are exposed to different social and economic factors, that different genders have different healthcare needs, and that resources should be distributed perhaps in an unequal manner in order to be equitable. Intersectional research is something that I'm sure people are beginning to hear more about. This was a term that the feminist Kimberly Crenshaw coined to identify how various groups within society experience overlapping levels of discrimination. So, for example, a racialized low-income single parent woman living in a marginalized urban area has a very different experience from a racialized single parent high-income woman living in a penthouse. So different individuals experience discrimination differently. And in terms of health research, intersectionality is used to outline how identifiable groups such as gender, ethnicity, people living within a particular geographic area, social or economic class, can have very different experiences with healthcare systems, and that overlapping patterns of discrimination can really impact on health outcomes. And then finally, gender-based analysis is an analytical tool that's used to assess the potential impacts of policies, programs, and other initiatives on women and men. So why does gender analysis matter? The research is really clear that societies where men and women and boys and girls are equal are better places to live. Health services and the health sector and the health system is an important institution within society. It's one in which individuals interface with throughout their lifespan, unlike educational institutions. And so the fact that gender has not been adequately integrated into health interventions is a missed opportunity to achieve better outcomes. Next slide, please. So it's clear that for the majority of the world's population, social and cultural perceptions about gender norms devalue and denigrate women and girls and undermine and restrict their social status, livelihood opportunities, and behaviors and freedoms. And they also, these same norms, promote risk-taking behavior among boys and men. And the provision of health services is never gender neutral, so it can exacerbate and alleviate gender inequities. So we know that gender inequality is suboptimal, but how do societies transform to a situation where women and men, boys and girls are valued and respected and are able to thrive? And what is the role of health services within that transformation? Next slide, please. So the research tells us that gender norms can change as a result of economic development or the spread of communications technology. They can also change through deliberate efforts to encourage change, such as new laws, policies, or programs, activism. And then individuals themselves can change as a result of exposure to new ideas and practices that get discussed through formal and informal channels, including the media. Next slide, please. So change is possible, but understanding gender can be really challenging. So this is a quote from a colleague of mine at Carleton University, who's a feminist economist. And she talks about how challenging it is to really undertake good gender-based analysis because data is often unavailable. It's hard to obtain in a timely fashion. We have these really ambitious goals in gender of equity, of full equity, and this can make gender interventions overwhelming. And often gender-based analysis talks about policy making, but what we really need is a more holistic approach where gender is considered at every stage and level of the policy process. And you're going to see how we're trying to do this in terms of the health system. Next slide, please. The other thing that makes the use of gender-based analysis and efforts to transform gender challenging is that it will encounter resistance. So this is a South African academic that wrote an article on how this resistance is manifesting itself in the context of South Africa, where boys are really resisting this effort to transform masculinity. Next slide, please. So what we're trying to do in our tools is really tap into this idea of a driver of change being an exposure to new ideas and practices. So we're hoping that health policy practitioners, health policy makers, through a better understanding of gender and also an understanding of what they can do to transform gender will help in terms of making health systems and health service delivery more gender transformative rather than gender blind. So what we're trying to do is provide an overview of these many tools that exist that have been developed over many years on gender and integrating gender into interventions, both development interventions as well as health interventions. So we're providing an overview of tools to try and ease the identification of appropriate tools that would be useful for you in whatever setting you're working in. We're going to be providing a searchable mind map, identifying key themes in the tools that enable you to see how those themes manifest themselves in the different tools that exist. And our goal is to have a simple umbrella tool or a conceptual framework that will allow you to better integrate gender. Next slide, please. So I'm going to now turn it over to my colleague, Amber, and Amber was responsible for reviewing all of the tools and coming up with a framework that she's going to share with you. So it's my pleasure to turn this over to Amber.
Thank you very much, Val. Okay, great. Thank you. Next slide. We're good. Okay, so here's a summary of the adaptable tools that I went over, and we do have a booklet that we consider sort of the toolkit that will be made available to you. But yes, here's the summary of the adaptable tools. Next slide, please. And this is the summary of the gender analysis tools that are specific to health that I collected and went through. And next slide, please. So this is the outline. And when you look at the toolkit, what I've tried to do is give you sort of an outline to follow to help you choose the right tool for your project. It's not in hard and fast rules, but it's meant to be a guide to help you, test some tools that might work better in some circumstances than others. And you'll see, excuse me, the titles provided. This should assist with researching where the tool came from, the background of the tool, who else has used it, and under which circumstances. The date, so we're going to do our best to provide a publishing date. Not all of them have it. And also whether it was still in use during our last update. The region, so we're going to attempt to update where the tool has been used, where it's been successful. And then we have the levels of analysis. So this tries to identify whether it's better for a micro-analysis, meso, or macro, or whether it's good across the board. The intended users or ease of use. So I've tried to highlight who the original tool was designed for and how easy it might be used for, or how easy others might find it to use. One of the things that we did find was some of them were overly complex if it was going to be a first introduction to gender analysis, and we're hoping to incorporate some of that into the umbrella tool. And then the relevance to healthcare and conflict and crisis affected states. So not all the tools are focused on the health sector, as I mentioned, or post-conflict environments. So we've tried to provide categories of relevance to help you scrutinize the tools most suitable for your project, and again, which tools might be adaptable. And then the specifics to identity. So although we feel gender analysis work should incorporate everyone in the process, some tools are focused solely on men, some are women, some are LGBTQI+. So we've attempted to underscore which groups or group the tool was originally intended for. And then the strengths and weaknesses. So our hope is that these will help you identify the strengths and weaknesses in your own project, as well as help you decide on which tools might best suit your needs. Next slide, please. And here we have some of the commonalities that we found in the tools. So gender-based analysis tools have been critically important for advancing our understanding and application of gender to health and development. Some of the shared things are transformation as well as equity. There's a need for gender disaggregated data, analysis of who does what, the division of labor, paid and unpaid, what resources are available, monetary and non-monetary, and who controls them, who controls formal and informal decision making, who controls the benefits of economic and non-economic activity. There's a focus on women and girls, very specifically reproductive roles and the ability to access health services. And then the development frameworks include women's empowerment, and then the health frameworks were more focused on equitable, effective, and efficient services. Next slide, please. And then some of the recent advances that we found in the tools. There's an increasing focus on an intersectional analysis, which Val discussed a little bit earlier. A focus on non-binary gender is now being taken into consideration. Gender in all aspects of health service research. And then a focus on power and power relationships. Next slide, please. And I'm going to pass this back over to Val, if you wouldn't mind taking over. Thank you very much.
Thank you. I just wanted to give a shout out to the RINGS team in terms of a gender analysis tool. This was an article that was in 2016 in Health Policy and Planning by Rosemary Morgan, Asha George, Sarah Sally, Kate Hawkins, Sassy Molino, and Sally Theobald. And it provides you with some guidance on how to do a gender analysis in health systems research. Next slide, please. And they have developed a framework that tries to get researchers to think about what really is a gender power relationship and how is that impacting on health. Next slide, please. One of the challenges that we see with the tools that they are really long and complex, that they're top down, particularly the health tools. They neglect what one framework calls the importance of conscientization, of awareness of gender. They focus on kind of the hardware, rules, regulations, and services. They don't really define what equity means. They assume an understanding of the concept of gender, of power, and an acceptance of the injustice of inequities among the population or among healthcare workers. They often fail to underestimate the challenges of change, the points of resistance, and the need to communicate with populations. And they also risk engaging in kind of a shaming of culture, values, and behavior instead of endeavoring to understand them. So what this is, and anybody that is familiar with behavior change communication knows that negative messages don't work. Positive messages tend to work much better. So they also neglect to incorporate software, how gender norms are interwoven within the fabric of society and can be perpetuated by social networks. Next slide, please. So given the number of tools, the complexity of the tools, and some of these challenges of tools, our goal is to provide an umbrella tool, what we call an umbrella tool. Next slide, please. We're doing that through our research that defines what a gender equitable health system is. So in our research, we stated that a gender equitable health system addresses the most urgent needs of men and women across the lifespan in an appropriate manner, ensures men and women are able to access and utilize services unimpeded by barriers, that they gather relevant sex disaggregated health information, and they provide equal opportunities for all health professionals working within the health system. Next slide, please. And so what we're trying to do is understand how the tools can help us get to a gender equitable health system. And that requires understanding what we call the bricks and the mortar. So some people use the word hardware and software in when it comes to health systems, understanding what the hardware of a system is, which is kind of the hospitals, the doctors, the healthcare workers. And then the software is how those things interact with one another. We prefer to use the terms bricks and mortar. So bricks is the system itself, what WHO calls the building blocks of the system. The mortar is what sticks that system together, what makes it work. So institutions such as health systems are embedded in and shaped by the interactions between people and those systems and within communities and families. So they're really impacted by gender norms. So social and cultural beliefs about the role of men, women, girls, and boys, how they should behave, how they should not behave, what life opportunities they should be given, how they should be treated, all of those things form the mortar that cements the health system together, pulls the health system together. So the mortar that we talk about are values, so how individuals and communities perceive gender, norms, how those values are reflected in practice, how those perception and values are reflected in terms of who has control of resources and decision making, and how that is also reflected in the daily workings of the system for patients accessing the system, but also for the system itself, for healthcare deliverers. And what are the factors impeding change, and what factors could propel change if you're looking at this idea of mortar, of values, norms, etc. Next slide, please. And then we also want to understand how the tools relate to the bricks. So this is much easier because there's been a lot of work that's been done. So we call we talk about gender equity benchmarks in the various building blocks. So our framework looks at how healthcare organization promotes gender equity, or should promote gender equity within the health system, how health service delivery needs to be accessible, integrated, and ensure equitable access to basic services, human resources, equal opportunities for men and women, health information systems, sex disaggregated data, health system financing needs to be equitable, and medical products and technology need to ensure equitable access to medical products and technology. But if you just look at gender equity in the context of the building blocks, then, and you don't also focus on the norms and values that we call the mortar, then it will be very challenging to achieve full transformative change. You will help to a certain degree, but your efforts might plateau. So next slide, please. So our key question in the use of the tools and the development of the tools is really, how can we use an understanding of the mortar and an analysis of the bricks to work towards transformative change in the health system and towards gender justice. Next slide, please. And we really, this needs to be a conversation. It's gender is very different in different contexts, and the people that have the most experience with understanding how gender norms manifest themselves and impact on the delivery of healthcare services and people's access to healthcare services really are researchers and practitioners that are working in those systems. And so what we would really appreciate is if you could provide us, look at the tools that we have outlined. They will be posted on the document that Amber prepared, will be posted on the website, and then provide feedback for us on what works for you and why, what doesn't work, what is missing, and whether this idea of bricks and mortar and our effort to categorize the tools into what tools address the bricks and what tools address the mortar is useful for you. So thank you very much.
So thank you very much, Val and Amber, for this excellent overview of the various tools and how they can be used, and how we can still put more work in it to get the most useful tools out of this and actually start applying them in concrete situation, which of course where it's needed. We have not received any immediate questions yet, but I do know that there are colleagues who are working on to post a question. So give me a minute. There's a question coming in now. Let me just read it and then we'll decide on who could best answer this question. So the speakers mention recent advances with gender frameworks moving away from the binary of men and women and being more cognizant of other groups. So I'm wondering why that definition of a gender equitable health system focuses also on men and women only. Val and Amber, that seems to be directed to you.
Okay, so our definition of a gender equitable health system should not just focus on men and women, and I'm grateful for you to point that out. It's kind of an oversight in our presentation, partly because of space. So the little circle that we provided was constrained, but I take that point, and we'll definitely integrate that into our work. Thank you.
Thanks, Val. It just takes the technology a bit more than just a raising of hands to have the next question going. Nanuka, do you have another question? Yes, it's coming. So here's another question. Is there anything related to perception of masculinity in the tools you reviewed?
So I'll let Amber answer that, sorry.
That's okay, sorry. Yeah, I had a closer look at the tools. Yes, there was some, but not nearly as much as I was actually expecting. The focus was primarily still on women and girls. So there's lots of room for improvement there, but there were a few tools that did, yes.
All right, so here we have another thank you for the speakers for the valuable insights. And we're wondering what advice would you have on adapting gender transformative approaches specific to the fragile and conflict affected settings?
So I guess I'll take that one. I think the first thing would be to understand that gender is not just men and women, that it applies also to, it's not just women and girls, that it also applies to men and boys and transgender individuals. There was a really great study that was done by UNHCR, commissioned by UNHCR on sexual violence against men and boys in Syria. And it showed the impact, it showed the prevalence of sexual violence against men and boys, and it also showed that health services were not, because they were geared to dealing with sexual violence against women and girls, were not responding appropriately. So I think that would be the first suggestion that I would have. The second would be to try and get as accurate data as possible, and to ensure, and this ties to the first point, to ensure that you leave your assumptions about who is most affected by conflict at the door, and just focus on the data. And then I think the issue of if you were going to look at building blocks, although we don't talk necessarily about building blocks in humanitarian settings, but if you're thinking about health service delivery in particular, I think it's really critically important to think about access, and especially with the whole agenda in the humanitarian world of trying to localize responses, of really thinking carefully about how you can support the localization of responses in a gender equitable way, to ensure that you're encouraging national healthcare providers that are working in really challenging situations to understand gender, to integrate some of the tools that we outline into their work. So thank you.
Yeah, thanks, Val. Obviously, a very intriguing question and not so easy. I do hear you that you talk, yeah, we should analyze, we should have data. And now one of the issues, of course, in those kind of environments is always the lack of data. So that's a bit of a problem. I don't know if you have an answer to that, please go ahead. Otherwise, we'll move to a next question. You may incorporate this later.
Yeah, I don't have an answer to that, other than donors should fund more data gathering exercises. And actually, one of the things that I think is interesting when it comes to data, and it's that organizations need to share their data more. And I think that this does happen to a certain extent in humanitarian settings where there's a broad international presence and better coordination. But I do think that, sometimes data is out there and people just don't know where to find it. So I think that might be something that that actors and researchers could try and do, is an initiative to encourage organizations, multilateral organizations, international NGOs, as well as national NGOs, to share their data.
Yeah, thanks. I think that's a good point. In real humanitarian environments, there is more data sharing, but if it's a bit more quiet or post-conflict, it's becoming less usually. So it's a good point to stress that. Then we have, in the meantime, quite a few additional questions. Could I pose this one to you? And if Hadja, if you want to also comment on this one, feel free. This is a question of how to ensure that frontline health workers, community health workers, get recruited, respected, supported, and paid, specifically in rural areas.
Thanks for that question. What's coming out strongly from the data that we have collected on community health workers is that with continued support to community health workers, they're strategically placed to challenge some of the gender norms that we have in our society. One of the tools that we use to collect the data is called Photo Voice, wherein we gave the community health workers a camera to capture what their work entails on a day-to-day basis. It could be something positive, something negative, something that they have advocated for and positive change has come about. And one of the pictures shows a picture of a healthy baby. And the narrative going with that was that there was another woman whose child wasn't thriving, and it was very quick for the community to classify her as a witch, or that maybe she was promiscuous while she was pregnant. That's why the baby wasn't thriving. But with the intervention of the CHW and him just saying that as long as the baby has access to good healthcare services, that could be reversed. So that was quite powerful, that picture that we captured. And another thing we also captured was that community norms can subvert practice. So again, community health workers are strategically placed to address that. So in general, we just need to support the software of the health system, what Val is referring to as the mortar, which in turn will support the community health workers in their role.
Thanks, Hadja. That's some good advices. There's another question which gets back to Val's talk, I think, and it's asking a bit more explanation about intersectional gender planning.
Sorry, the question is just asking for more explanation on how to do intersectional analysis in gender. I think one of the, I'm just thinking about some recent work that we did on humanitarian settings and healthcare workers in those settings. So an intersectional analysis would understand that various humanitarian workers experience their job and their context in very different ways and are differentially affected by social, political, and economic context. So an international humanitarian worker who is a woman from Canada, for example, has a very, very different experience as a health worker in a crisis setting than a national health worker who could be from a racialized minority, could be from an identity group that is a conflict in that, or is subject to particular discrimination or violence in that setting. So it's that kind of analysis. It's understanding that there are varying groups of individuals and that just because you're male or you're female doesn't mean that that's the only level of analysis that you need to undertake when you're looking at how they are engaged in health service delivery, how they're impacted by their context, how factors that might affect their access to healthcare services, that there's multiple layers of analysis that you need to undertake in order to do that. So I think, you know, if you look at really good work done by epidemiologists, they do some of that. They do look at, they try and provide data that disaggregates by age, that disaggregates by gender, but also looks at geographic area, also looks at particular identity groups that might be relevant. So it's just taking that and understanding how how different groups experience their environment differently.
Right. Thanks for that explanation. It's so let's move on to, yeah, it is quite a bit of a different question. It's about budgets and ministries of health, and the question is, how can we ensure that women's needs and men's needs are integrated if the Ministry of Health has not enough budget? Is there any thought on that?
Yes, you know, that's one of the challenges when we looked at health systems, is to distinguish between health systems that are just under-resourced versus health systems that are truly gender inequitable. And so that's a big challenge. And the scarcity of financial resources is a reality in many health systems, most health systems throughout the world, and in some cases more severe than others. There is an effort to undertake what they call gender budgeting. So it tries to show how budgets can be better allocated to respond to the varying needs that men and women, boys and girls, and other genders experience. We haven't yet included gender-based budgeting within our toolkit, but I think it would be a useful one to integrate. And then the other point that I would just make is that there's a lot, you know, there's a lot that can be done that doesn't cost any money. So one of the things that was clear in our research, and this was across multiple cases, was just the value of encouraging healthcare workers to treat patients with dignity. You know, that doesn't cost money to do that. And often the way that women are treated when they access healthcare services can be a reflection of misogynistic gender norms, which are existing in that particular society, and that is a barrier for some women to access healthcare services. So while, you know, definitely financial resource shortfalls are problematic in terms of healthcare systems, there are, you know, when you look at what a gender equitable health system should be, it is clear that some of those interventions don't take money. It's about addressing and confronting gender-based norms in order to ensure that people are valued equitably and equally.
Yes, I think it's not all about money, but it does help usually. Now we have a few questions. I think they can be combined. They are probably coming from the same participant, and it's about, is there a particular tool that was helpful for framing and working with transgender populations, sexual minorities? And then the consequent question is, has this tool been piloted in areas that are not considered post-conflict settings in South Africa? And if so, what have been some of the results? And then there's also probably a question related to it. If you could explain a bit further what you mean by binary gender analysis.
I can just mention that in the tools that I looked at specifically, the only one that took that into account was the rings one. So if maybe I can turn it over to one of my colleagues that that worked more closely with that, and they can talk about that perhaps.
Yeah, I'm not sure if maybe the people that developed that tool might not be online, but I would encourage you to look at that particular tool. I think that it's really one of the weaknesses of the tools that we looked at, and part of that really reflects the fact that some of these tools are from 20 years ago, 25 years ago. So yeah, I think that definitely is an area that needs more analysis. I'm not sure if that, and in terms of piloting, it might, it's not an area that we focused enough research on, but it would be definitely worth a look to see if and how those tools have been piloted. And those are things that we would encourage you to do if you're in a position to be able to integrate some of those, particularly the rings tool that addresses non-binary and transgender populations. That would be terrific.
Yeah, thanks. So I think this is already a clear result of this webinar to identify this so far under-researched component in the analysis and also in the tools. Let's move on to see to what extent do the tools also cover mental health care as well as nutrition. There was something on the slide, but the participant thought it was passing by a bit too quickly to look at.
I can probably speak to that. There wasn't a lot of focus on either of those in particular. They're important aspects that we need to include, but I can't think of a specific tool that really had that as its primary focus. If that answers the question.
Yeah, again, another gap that would clearly need to be addressed, and this is one of the challenges when you look at these tools. We want a simple tool, but then the needs are many, and so how do you balance that need for something that's simple and that can be applied in multiple contexts for one that is comprehensive and addresses multiple sectors. So
there is a suggestion from Rosemary that she could also have some suggestions, but she needs to be unmuted. Nanuka, is that possible?
Sure, Egbert. I will right now unmute Rosemary. Just a second. Rosemary, now you're unmute, so we can hear you.
Hi, thanks very much. So I'm Rosemary Morgan, and I'm part of the RINGS team, Research in Gender and Ethics, Building Stronger Health Systems, and I'm based at Johns Hopkins Bloomberg School of Public Health. And thanks everyone for a really interesting presentation. This is really important work, bringing together the different tools that are needed and expanding on the tools and seeing where the gaps are. I think I brought that comment in when the question came up about non-binary approaches and thinking also about, how might we look at transgender populations. And in RINGS, we predominantly do work in low and middle income country contexts, which are, when we think about gender, it does tend to be very binary. So looking at men and women, boys and girls, and as Val said, often gender is thought about as women only, which is not the case. We have in RINGS tried to push the tools and frameworks forward to take an intersectional gender lens, which Val is very, very excellently kind of summarized and explained, to move beyond that binary approach, to bring in other other individuals. So looking at what is gender and how does it intersect with sex, with age, with class, with location, with disability, sexuality, and that is to try to expand our knowledge on and our work that we're doing within these different contexts and different groups to understand how marginalization and disadvantage play out and how power and privilege play out. And I think I'm just kind of reiterating what Val said, is that there is very little work done in this area actually on non-binary approaches, mainly because of the reality of the situation. And the context that we're working in, and there's much needed work to think about tools explicitly for these populations that are more marginalized, are more disadvantaged. And I would reiterate Val's call that, if people are interested in moving that work forward, it's definitely something that's needed. Thank you.
Yeah, thanks so much, Rosemary. Sorry, Egbert, can I just jump in there? I think that was great. Thanks so much, Rosemary. I didn't realize you were on the line, and I'm really grateful that you were able to provide a summary of the work that you did. And I just wanted to echo the Rosemary's point about transgender populations, and just to note that in that UNHCR study on Syria, it's called "We Keep It in Our Hearts." That study did find that transgender population, there were a big data sets of transgender populations that they looked at, but they did find that the vulnerability of those individuals was much, much higher, and it's clearly an area that has not been sufficiently researched, and I think we're missing something really important in terms of addressing vulnerability.
Right. Okay. Thanks, Rosemary, for popping in and giving your comment. And Val, thanks for responding to that. In the meantime, I think there were some people asking questions. Yeah, they are interested, of course, to see the actual toolkit, and I'm wondering if it will be shared and how. So yeah, definitely it will be. It's still in due course, but all the participants who have signed up, they will be emailed when it's out, and so you can access the actual toolkit, just to reassure you that will happen. I have another question here that's more related to human resources. There's a question if there are any tools to help human resource managers analyze their human resource databases from a gender perspective that do more than simple disaggregate of jobs by male and female. For instance, an analysis of career progression. So
wow.
Answer this question, if this is your field, or is it a bit beyond it?
I have, oh, sorry, go ahead, Amber.
Oh, I was just going to say, so there was nothing that was specific to this, but there were certainly tools that could be potentially adaptable so that gaps can be filled in that regard.
Yeah, I think that's exactly the kind of analysis that's needed, and the tools would point you to kind of the questions that you need to ask and how you analyze data. But I don't think that there would be anything stopping human resource managers from doing that themselves if they have a database and you are able to access identifiers on human resource health workers. I think that that's something you could just do and see what patterns emerge. I think in the case studies that we looked at, I didn't see a huge amount of gender analysis on the healthcare workforce, with the exception of emerging research that's being done by Rebuild on gender and community health workers, and I would encourage you to look at that.
Yeah.
Sorry, can I just add something? So we have also published in Health Policy and Planning a paper, and it's on the reference list at the end of my presentation. So this was looking at, so we looked at human resource for health data, but also spoke to the healthcare workers and analyzed using a gender lens. And it was in 4 post-conflict countries, which is Northern Uganda, Cambodia, Zimbabwe, and Sierra Leone. So the details of that could be found in my reference list at the end of my presentation.
Yeah, thanks for that, Haja. So that's will be all visible. I'm sure everyone will also have access to the slides by the end. So that's where you can look back to those references. There's another type of question, which is pointing out how ambitious can we be in terms of gender and in a humanitarian emergency. So the question is that, given the temporality of humanitarian response, is it possible to be gender transformative in an acute emergency response, or can we be gender sensitive at best?
I think that it would be possible to be gender transformative in terms of the own sphere of influence that you have. Definitely humanitarian contexts are incredibly challenging. And one of the reactions that we've gotten when we've presented the research on gender equity in health systems has been that health workers already feel so overwhelmed that we're asking them, you know, to engage in gender transformation as well, and they do see that as daunting. But I think that when you think about about gender and about the interface between the population and humanitarian workers, as well as about how the humanitarian workforce treats its own employees. And we've had revelations of a whole Me Too movement within the humanitarian sector as well. I think that there clearly is a challenge, a problem in humanitarian action of it being not even gender sensitive, but gender blind and perhaps even perpetuating negative gender norms. And I do feel that there is an opportunity to engage in a small effort within the sphere of influence of that particular health service, to think about, you know, gender in terms of men and women, access to services, and treating people with dignity and respect.
Right. So let's move away from the immediate humanitarian response to a more system level question. It's not an easy question, so I'll read it and hope you can see it also for the listeners. It's a bit of a long question. So there's a person who would like to ask how gender can be operationalized for system level analysis, where the unit of analysis are not the attributes of individuals, but of organizations, markets, regulatory agencies, or countries. And are there gender attributes to operationalize these upstream and abstract entities of the health systems?
Yeah, that's a really interesting question, and it's something that we've kind of spent the last 5 or 6 years grappling with. How do you look at gender as it manifests itself within the entire health system, and with, you know, rather than just at the interface between a healthcare worker and a patient? And if you go to the website, the Building Back Better website, you'll see that there is an effort in our research to, and I reflected it in my presentation, to establish what we call benchmarks for gender equity. We really struggled with how to analyze gender within the context of these very complicated, complex systems. And so what we did is we used the benchmarking approach, which has been used in other health system analysis, so in terms of comparisons of health systems, for example. And we defined what a gender equitable health system would look like, which I outlined in my presentation. And then we tried to evaluate the extent to which the health system met those gender attributes, and then within each building block, we established kind of a benchmark of what healthcare financing would look like. And I went into those in a little bit of detail in the presentation, but much more research has been done on that, and it will be available on the website. So an excellent and challenging question for sure.
And then another challenging one that's even going beyond the health system, and that reads that gender issues and challenges are beyond health systems. And if you have any thoughts on how buy-in and ongoing intersectoral approach with underlying health in all policies is achieved.
I think so. Intersectional approaches, and I think that most of the efforts that I've seen, and I may be missing some, most of the health system engagement has really, as we reflected in our presentation, has really focused on gender as an issue for women and an issue for women's reproductive roles. So looking particularly at maternal health and reproductive health. So I haven't seen that kind of broad analysis and efforts to use the health system to engage in gender transformation. I think, and I can't see the question, so maybe I'm not remembering correctly what it is, but in terms of some of the approaches that I think work more broadly, and it gets back to the slide that I presented on how do gender norms change. One of the things that's particularly interesting and innovative is the use of dramas in order to kind of model, use both radio dramas and TV dramas to talk through some of the gender norms that are manifesting themselves and impacting on people, and I think impacting negatively on people. And there has been some analysis done, I believe, by the MIT Poverty Lab that shows that some of these dramas have a really important impact in terms of reducing gender-based violence, for example. So I think, definitely you need broad approaches, and you need really innovative approaches, and you need to get at values and norms. And I think one of the things that we've been doing both in the health sector and elsewhere is focus on, okay, what are the ingredients of a gender equitable health system? Oh, it's women in parliament, it's women in the military and the police, it's ensuring that we provide reproductive health services and maternal health services. And all of those things are important, but they've proven to be insufficient because of this lack of a broad focus on, what we call the bricks and mortar of health systems, but it would apply equally in other sectors in society, I believe.
All right, so this is quite far-reaching.
Can I just
Yes.
Sorry, Egbert, can I just add something to that? In the context of Sierra Leone, there was a missed opportunity for intersectorial action, wherein we have a Ministry of Social Welfare, Gender and Children's Affairs, and we have the Ministry of Health and Sanitation, but they don't necessarily talk to each other. And in the post-Ebola phase, a post-Ebola reconstruction policy was developed, but unfortunately that did not speak to gender. And if you think about what I said, that during the Ebola outbreak, yes, women were at risk because of their caregiving roles and also where they're placed within the health sector. And also men were at risk because of the role they play in burial rites. So what do we do about that? I think moving forward, we should ensure that we build strategic intersectorial alliances moving forward.
Thanks, Haja. And I just wanted to start saying that we are slowly winding down our webinar. It's near 4:30 at my time, at least. So I still have one question for Haja, and then I think we wind up with 2 or 3 slides, then we call it today. So Haja, could you answer the following question? that reads, does the analysis you did in Sierra Leone on community health workers look at the negative side of the role of community health workers? Is there no possibilities of women plunging deeper into poverty if the community health work is done for free or for a nominal wage or salary?
Thanks for that question. With the new CHW policy in Sierra Leone, there is financial incentives attached to that, which is considerably more than what they were getting before. What we have captured with regards to financial incentives is there has been challenges in actually paying CHWs, but that cuts across all gender, men and women. So I think it emphasizes the point, but that's more of a systems issue, but it emphasizes the point that they should be paid. It's not acceptable that they're working and they're not being paid. But we did not look at that from we didn't analyze the data in a negative light.
Okay, thank you, Haja, again. And I think it's already time indeed to wind up, and I'm asking Nanuka to give us the next slide, but that gives me the opportunity to give a great thank to, first of all, Haja, to introduce the case study and to bring us to Sierra Leone, to where things do happen on the ground, not least, of course, during the Ebola crisis, which you all remember, but it's an ongoing struggle to get things going there. And then in particular also to Amber and Val to present us the toolkit and the rich discussion we could have. It's always a pity for webinars that we're not really going to up and down the discussions, but I hope you have enjoyed at least listening to some of the questions people ask and the answers which could be provided by Amber and Val. Thanks a lot for those not easy task to answer those different questions at such short notice. So as we are coming to the end of the webinar, I think on your screen you see that you will receive an email soon with some details on how to feedback. And then you will also receive the webinar presentation and the recording, and then how to even further comment and feedback on the draft toolkit. And you may also, even if you found this whole webinar interesting, you could share this information with other colleagues to still listen to the webinar. And as we already said, when the final toolkit is launched, we will contact you again. You get the details and you get a link to download and to see the kit. Could we have the next slide? So I think this was the end of our webinar. I think as we started, it was part of hosted by the TWG on the thematic working group on health systems research in fragile and conflict affected states, which is a part of the Health Systems Global. And then we mentioned that Health Systems Global is organizing every 2 years a major symposium. And this is just to remind you that the next symposium will be pretty soon. In October, 8 to 12 October. It's in Liverpool, easy to reach, fun place. So please come and join us there. Can I have the next slide? So this is the end. You see the logos of the various groups which have contributed to this webinar, which I personally found very enjoyable and a lot of lessons to be learned. So thanks to all of you, and we hope to see you again one day in one of our next webinars or in any other venue. Thank you very much.
Thank you, Egbert, and thank you to all the panelists for a very interesting webinar today. And please do not forget to participate in the post-webinar survey. This really helps, your feedback really helps us to improve the quality of the webinar. Thank you and bye for now.